Hello and welcome to EcoMap, the practical, easy, and above all useful ultrasound for general practitioners. So today we have a typical case from general practice where clearly ultrasound could have failed if we hadn't used Doppler. And that's why, as you'll see, this is a perfect example. When I tell you that every image examined with ultrasound absolutely needs to be checked with Doppler, well, here we're going to see a perfect example of that. But first, if you like this channel, as always, give me a like and subscribe to the channel. That way you'll be notified when new videos come out. And it also encourages me because it shows me that this extra work I do at the end of my general medicine consultations is actually useful for you, that it helps you, and that it's not a waste of time. Same thing on Facebook, give it a like and follow the Facebook page. And right now, the introductory EcoMap training is still being offered for free. The link is in the description. I really encourage you to join me in this training too, to try to go further and learn how to use an ultrasound device and see how it can be useful in your practice, in your office. Because honestly, I can't encourage you enough to bring this amazing device into your consultations. It provides a huge amount of help for you and your patients. So here we have the simple case of a young patient who comes to see me because she noticed a lump on the back of her head. There you go, and it's worrying her. Sometimes it's smaller. Other times she feels like it's a bit bigger when she touches it, and she'd really like to know what it is. It's absolutely painless to the touch, and clearly quite firm when you feel it. So, with direct contact on the scalp, I thought it might be an exostosis. I told myself, it's really firm under my finger. We'll quickly confirm that with the EcoMap device, and overall, the problem will be solved, and the patient will be reassured. So I start my EcoMap using a high-frequency probe. You recognize the linear probe, and here's what I get. At this point, I tell myself, this isn't an exostosis at all, actually. We have two images. Let's describe them together a bit. We have two images that are basically anechoic, or at least very strongly hypoechoic, within the scalp. Here you can see the scalp, this somewhat distinctive appearance, just in front here of our bony cortex. And then we have the equivalent of two anechoic lesions. So in dynamic mode, here's what it looks like. Let's explore a bit. Ultrasound is always something dynamic, so we can see that it's indeed right next to the skull. It's most likely, in any case, fluid-filled. And so this completely calls into question my diagnosis of exostosis, since we would have seen a deformation of the cortex, and that's absolutely not the case here. While exploring, we noticed there are some small areas here that might be a bit echogenic inside, so not completely anechoic. I feel like I see something here. Here too, maybe something a little bit linear within the anechoic images. And then why not some posterior enhancement here and here? So this again calls my diagnosis a bit into question. I thought, well, maybe go with a sebaceous cyst in this case, an epidermoid cyst, since inside you can have keratin inclusions that will be hyperechoic within a sort of mass that's usually hypoechoic, or possibly even anechoic. And then this posterior enhancement, it's still hard to say, but this impression of posterior enhancement makes me think it's really something fluid-filled. So this posterior enhancement, why do I say it's hard to tell? Because very clearly it feels like we can see it well. Well, we have the skull here, and the skull, especially in areas that are perfectly perpendicular to the probe, will be the source of reverberation artifacts. Reverberation artifacts related to, bone calcifications, which can give the impression of seeing posterior enhancement here. So be careful when structures are really close to the bone, because it can be extremely misleading. And I always find that concluding there is posterior enhancement when you're right up against the cortex is very risky, and there's a high chance of making a mistake. So as I mentioned in the introduction, every finding on ultrasound should be checked. Well, should be checked with a Doppler scan, because Doppler will help clarify a lot of things. Every structure found on ultrasound should obviously also be measured, as was done here, since that allows you to record it in the medical file and assess any changes later on if you need to do another ultrasound. Here, then, we have our two cysts, I'm saying cysts in quotation marks, which are about 8 millimeters and 7 millimeters, so they're small, minor lesions on the skull. You can already see that the EcoMap has given us a lot, since the clinical exam pointed towards something bone-related, but here we're more likely dealing with something tissue-based or fluid-filled. And the clinical exam pointed toward a single lesion, but in the EchoMap, we actually found two lesions. Now, the Doppler. At this point, the Doppler completely changed my thinking, and that's why I'm telling you that you should never draw conclusions before using the Doppler. With the Doppler, we actually see a signal, a clearly visible signal within this anechoic area that seemed to be fluid filled. And here, the Doppler calls everything into question because there's no reason we should see a Doppler signal inside a fluid collection. We're going to rule out this diagnosis of a fluid lesion 100%, based solely on the Doppler findings. That's very important to understand. How's our Doppler look? Our Doppler is actually pretty well organized, probably central, and it seems to originate from that small echogenic structure we noticed at first. Same thing here, at this level. We also have this small hyperechoic structure, which I think is keratin from an epidermal cyst, which seems to be in agreement with the Doppler. We will continue our exploration. You can see here that I have improved the image a little bit, and we really have two very central vascularizations of this lesion, and that obviously makes us think of a hilum of lymphadenopathy. There you go. We're starting to make progress. So you can see how we went from a clinical situation where we thought it was something bone-related to a first ultrasound that jumped to conclusions a bit too quickly, calling it a cystic fluid lesion, maybe epidermoid, and finally, the Doppler sets everything straight by pointing us toward a simple lymphadenopathy. In fact, two simple lymphadenopathies. We're going to do a Doppler, this time a pulsed one, to take a closer look. Typically, we see a low-resistance, visceral-type flow, which is very common in lymphadenopathies, especially when they're post-reactive. We're going to do a microflow Doppler, just to analyze the flow a bit better, and notice how much vascularization there is throughout the entire structure. So it's absolutely not liquid, it's completely tissue-based. Here, of course, we can see the main vascularization, which is the hilum, sending out a few branches. And you can see that within the tissue here, we have a very weak Doppler signal, which is normal since the vessels are much smaller, but they're definitely present both in this structure and also in this one. So as you can see, in the end, this is a completely tissue-based lesion, contrary to what the ultrasound initially suggested. The second lesion is exactly the same, you see. A lymph node with a well-organized central hilum and then a bit of overall vascularization of our lymph node. Here you can see what it looks like on a dynamic image. So you really see the importance of always, always, always finishing your echo map with a Doppler scan. It's really essential if you want to improve and avoid diagnostic errors here. So obviously here we have two lymph nodes, two benign lymph nodes with a size less than 1 centimeter. As we've clearly seen, two oval-shaped lesions. A ratio of 1 to 2 is what's recommended to conclude, or at least to lean toward, a benign lymph node lesion. The borders were very clear, very regular, with well-defined edges, a hyperechoic central hilum that we could barely see. We could kind of make it out, which made us think of keratin deposits. In some cases, this central hilum can be hard to see, especially when it's difficult to scan around the lesion. And that was the case here, since the patient had braids on her scalp. So actually, I couldn't position my probe exactly how I wanted, and so I was missing part of the ultrasound, which is the double grid, a central vascularization that was perfectly visible here, both with power Doppler and with microflow Doppler. A homogeneous hypoechoic echo texture that, in some cases, especially in post-reactive lymphadenopathies, can be completely anechoic and very misleading. It can mimic an abscess, it can mimic a cystic lesion. So be careful, especially when the clinical picture gets mixed up and you're not really sure anymore. You really, really need to remember to use your Doppler. There's an absence of calcification or cystic spaces. A cystic space will appear as a generally hyperechoic lymph node with small anechoic circles inside. This is more for the thyroid, cervical lymph nodes, but I wanted to mention it here. So there you go. I hope you found this case interesting and that it reinforces the idea of always taking a few seconds to use the Doppler. And I guarantee you that if you do it systematically, there will definitely come a time when you'll change your mind about your diagnosis, just like in this case. All right, see you very soon on EcoMap. Remember to give a like and subscribe. Same thing on Facebook. And go ahead and take this training because it'll help you improve too. All right, see you soon. Bye-bye.